Hello, so today we're going to talk about the child with cancer. One of the things that you'll probably notice as you're following along is that I may not follow the chapter section by section or paragraph by paragraph like I tend to do usually. I found that this chapter was a little less organized than some of the other chapters in this book. The other thing that I wanted to talk to you about too is that I'm not sure why they decided to put like the blood cancers in here when in actuality they could have covered them in the hematologic chapter, kind of like they covered the bone cancers in the uh, mobility chapters. And same with the neuro cancers. But I think that they did that more because they wanted to cover cancer treatments all in one spot. Could have had a short little chapter, but everyone organizes things differently when they come up with things. So we'll head right on into this chapter now. Childhood cancer is fairly rare. We hear about it a lot, and if you work in a children's hospital, sometimes you feel like it's an extremely common thing. But despite all of that, each year about 1,300 children die of cancer each year. As far as the etiology is concerned, they feel that there's a genetic alteration that results in an unregulated proliferation of cells. And if you think back to when we were talking about cancers and pathophysiology, if you remember, childhood cancers tend to be associated with fetal type cells, where adult cancers tend to be lifestyle alterations in how the cells function. They feel like although cancer is the result of multiple genetic events, it's not necessarily hereditary. There may be immunodeficiencies that are associated with it as well. Unlike adults that have factors that are associated with their lifestyle, like smoking and things like that, for children, the known risk factors include things like ionizing radiation, the receipt of carcinogenic drugs, immunosuppressive therapy, certain infections like Epstein-Barr viral infections. There is some prevalence as far as racial backgrounds are concerned, and there are some genetic conditions that increase the risk of developing cancers. Primarily, the thing that we look for, especially in the older child, is to have them prevent cancers by prevention of activities that cause the adult type of cancers like smoking and drinking. Some of the symptoms that we see with cancers, and it's important for us to be able to spot these, is an unusual mass or swelling, unexplained paleness or a loss of energy, sudden tendency to bruise in a child that hasn't had that problem in the past, persistent localized pain or limping, although pain in general tends to be a later sign in children than an early sign, prolonged unexplained fever or illnesses, frequent headaches, often associated with vomiting, and as you recall, that is really associated with neurologic changes, or a sudden eye or vision change. When we look at the various types of diagnostic evaluations used for cancer diagnosis, we see that the majority of patients have a complete blood count or a CBC, serum chemistries, so we're looking at electrolytes, liver functions tests, coagulation studies, and urinalysis done with the initial presentation. Often after the diagnosis is made, we continue to have frequent CBCs to monitor the effect of therapy, also to make sure that the therapy is not causing more side effects than what is necessary, or that we may need to treat based on the side effects of the therapy. Also, we're looking at blood chemistries like electrolytes to get information as far as kidney, liver, and bone function, and to make sure that the electrolytes are balanced. As far as diagnostic procedures, LPs are very often done, or lumbar punctures, especially when we're looking at things like leukemia, brain tumors, and other cancers that could possibly metastasize to the CNS. They're also used to administer intrathecal drugs in patients with CNS type malignancies or in leukemia. A bone marrow aspirate test is often performed by aspirating the marrow with a large or a fine-tooth needle. We can also do bone marrow biopsies in the same manner. And so when we do these, we're looking for abnormal cells, or we may actually be getting bone marrow to for donation at a later time period. When we look at diagnostic imaging, we often see chest x-rays, CTs, MRIs, and PET scans being done to evaluate and follow up on tumors. As far as pathologic evaluation, it kind of goes along with the diagnostic procedures. So if a biopsy is necessary, it will establish the diagnosis of malignancy, and it will also help us to follow up as far as whether or not it is responding to therapy. When we look at treatment modalities, surgery is often done with solid tumors. And because the majority of pediatric cancers respond fairly well to chemotherapy, we're getting so that we're not doing such radical surgery excisions. And so we're able to preserve function and cosmetic appearance of the children that have these cancers. Chemotherapy is one of the primary forms of treatments, or it can also be done as an adjunct to surgery or radiation. The majority of the chemotherapy agents work by interfering with the function or the production of nucleic acids like DNA or RNA. And although several drugs with anti-neoplastic capabilities have been effective in treating different forms of cancer, it's resulted in remarkable survival rates with the improved combination of drug therapies. When chemotherapeutic and immunologic agents have anaphylactic potential, it's standard practice to observe the child for at least an hour after the infusion for signs of anaphylaxis. So if you remember that anaphylaxis is associated with rash, urticaria, hypotension, wheezing, nausea, and vomiting. Emergency equipment, especially things like blood pressure monitoring, bag and valve mask, and suctioning is necessary to be readily available when these drugs are being used. And then emergency drugs like epinephrine, antihistamines, aminophylline, and steroids and vasopressors also need to be available when children are receiving these medications. Radiation is frequently used in the treatment of childhood cancer, and it's sometimes used in conjunction with chemotherapy or after surgery. It can be used for curative purposes or for palliation to relieve the symptoms by shrinking the size of the tumor. And in some cases, they shrink the size of the tumor before they do the surgeries because that leads to better outcomes. Bone marrow transplant is another approach to treating childhood cancer, and we're going to talk a little bit more about that in just a few minutes. And basically, it has resulted in us being able to treat cancers in a different way with less side effects and longer term outcomes for these patients. Some of the things that we have to worry about as far as pediatric oncology emergencies can come either before the diagnosis and could actually be part of how we find out that a child has the cancer, or it may be a result of treatment or just the progression of the disease. The tumor lysis syndrome shows metabolic abnormalities that are the direct result of the rapid release of intracellular contents during the lysis of malignant cells. Sorry, I'm having a hard time getting those words out today. Basically, what we see with that is as these cells are being destroyed with treatment, they break open and their internal contents come spilling out into the system. So what ends up happening is we start seeing hyperuricemia, hypocalcemia, hyperphosphatemia, and hyperkalemia. So think about the side effect or the symptoms and what happens to the body when those abnormalities are present. Also, we can get crystallization of uric acid and with the hyperuricemia, and that can lead to obstructive nephropathy, tubular injury, acute renal failure, and potentially death. So the symptoms that we see with children that have this is flank pain. Think about it because we have that crystallization, lethargy, nausea and vomiting, muscle cramps related to the hyperkalemia, the hyperphosphatemia, the hypocalcemia, pruritus, tetany, and seizures. Although the book doesn't talk about it, if you think about someone who has hyperkalemia, we would also see abnormalities in the heart function. The management is to monitor the serum chemistries and the urine pH frequently, have strict I&O, and use aggressive IV fluid. So basically we're sort of diluting these hyper levels of these electrolytes. The medications are used to reduce the uric acid formation and promote excretion of the byproducts of the purine metabolism. So we're going to use things like allopurinol for that. If the tumor lysis syndrome occurs, we give IV hydration and then we try to adjust the specific abnormalities that we see. And so basically that's kind of the bottom line with that. And then another thing that can happen is hyperleukocytosis. Hyperleukocytosis is when the peripheral white blood cell count is greater than 100,000 per millimeter cubed, and that can lead to capillary obstruction, microinfarctions, and organ dysfunction. Some of the symptoms that we see is respiratory distress and cyanosis, The kids can also have some neurologic changes, including altered levels of consciousness, visual disturbances, agitation and confusion, ataxia, and delirium. The management of this consists of rapid cytoreduction by chemotherapy, hydration, urinary alkalization, and use of allopurinol. Sometimes they'll do leukapheresis or exchange transfusions as well. So I wanted to talk a little bit about that because leukapheresis is very similar to hemodialysis. And with exchange transfusions, what we do is basically we have two IVs in a child, and on one side we're pulling the blood out, and on the other side we're putting blood in. So basically we're replacing the blood that we're taking out at the same time. So it's not like we're taking blood out and all of a sudden putting it back in again. We're kind of doing it simultaneously. So what happens is initially you are taking out this blood that has all of these abnormalities in it, and then you are diluting what's in there with the transfusion on the other side. And so over several passes, you get to a point where it greatly decreases the number of white blood cells that are circulating in the bloodstream to a more normal level. And exchange transfusions are used for other purposes as well, but basically the idea is that from one vessel you're taking out the concentrated levels of whatever it is that you're trying to remove, in this case excessive numbers of white blood cells, and on the other side you're putting in blood with normal amounts, and so you're gradually reducing the level of those components. With superior vena cava syndrome, we get airway compromise and potentially respiratory failure. It's caused by space-occupying lesions. And so what we get for symptoms with this is cyanosis of the face, the neck, and the upper chest, facial and upper extremity edema, and distended neck and chest veins. The children may be anxious, they may have dyspnea, wheezing, or a frequent cough caused by airway obstruction. The management consists of airway protection and alleviation of the respiratory distress. Rapid treatment is initiated and the symptoms typically remove as the disease is effectively treated. And in this case, we're actually looking at surgeries being done to remove those occupying lesions. So we've got a big tumor in there, we're going to remove the tumor. Spinal cord compression is when there's an invasion or impinging on the spinal cord that causes acute symptoms. Back pain is the most common initial manifestation, but some of the other symptoms that can come with this is sensation changes, extremity weakness, loss of bowel and bladder function, and respiratory insufficiency. We want to do a careful physical examination for early detection of the symptoms, but the MRI is the gold standard for diagnosis of this. High-dose steroids reduce the associated edema and alleviate the symptoms, and rapid initiation of treatment such as emergence radiation or a laminectomy, if indicated, is done to relieve the spinal cord compression. One of the things that we look at with kids with cancer is that they have an increased susceptibility to infection. And this is both at the time of diagnosis and also if they have relapse. It can also occur during immunosuppressive therapy and after prolonged antibiotic therapy it predisposes them to growth of resistant organisms. So one of the things that I want you guys to pay attention to is figuring out absolute neutrophil counts. And no, I'm not going to put that on as a math question on your test, but this is something that's very good for you to know, because anytime you're in a infectious or oncology situation, they're always looking at the absolute neutrophil count to evaluate the level either of infection or how well this person could be able to fight off infection. You'll see this again when you start going into those topics in med-surg. So this definitely would be something good for you to pick up. I would say that, if I can figure out a good question on this, there may be a good question that's out about absolute neutrophil count. But in general, I want you to get this idea figured out and how they figure out what the absolute neutrophil count is in patients. The other thing I want you to take a look at are these critical thinking case studies that are being presented in this chapter. Understanding the oncology side of pediatrics is going to be very, very beneficial for those of you that have clinical with me over the summer, because we are going to be on the hematology oncology floor at Cook's. And so it is going to be very valuable information. And so I would look at these case studies. The first one that I noticed had a lot of things in that history that should have made you go, ooh, that must be this, or ooh, that must be something else. So definitely look over those case studies and try to figure out what's going on in them, because that will definitely help you out in clinical. The other thing that we have to think about is infection control when we're thinking about the high risk for infection with these patients. And so environmentally, they can't have any live plants with them. We don't bring flowers into them. We don't bring in potted plants for them, because there is more bacteria and fungi and things like that that's around those plants. So we don't want to increase the risk environmentally of infection. Hand hygiene, like always, is extremely important. We have to make sure that visitors that show any kind of symptoms of infection are not allowed into the room to visit, because they don't have the ability to fight them off. And nutritionally, these kids don't get fresh veggies, so no raw carrots, no raw broccoli, or any of those kinds of things. Their vegetables have to be cooked, because again, back to the same idea of no live plants or flowers, we can't give them things that have not been put in a situation that can kill off the bacteria. We also have to think about talking with parents about planning for home care and thinking about the same kinds of issues in the home. Your book talks a little bit about chemotherapeutic agents and some of the things that you have to think about as far as managing those, but also giving those agents. Vesicants are sclerosing agents, even in minute amounts. And so it's part of why people have to wear gowns and gloves and protective equipment when preparing them. We have to be aware of the interventions for extravasation if that should occur with the patient. So we have to be able to neutralize those chemicals to decrease the amount of damage that they're causing in the tissues. They also hold a lot of risk for anaphylaxis, and so we have to be very cognizant and evaluating our patient for signs and symptoms of anaphylaxis so that we catch it and treat it early rather than getting them to the point where they're very ill. And we need to have those medications available at that time. As far as managing problems of drug toxicity, there's a certain amount of toxicity that always takes place with chemotherapy because that is how we're killing off the cancerous cells. And so what we often see with our patients is anorexia, not because they don't want to eat, but because the medications cause them to not want to eat. And we'll talk about some of the other reasons behind that. We often get mucosal ulceration, and with that mucosal ulceration, it can be anywhere from the mouth all the way down to the rectum. And so the GI tract itself is irritated. It becomes painful for food to pass through those areas. We have to give medications for the children to reduce the pain that they have in their mouth, and often have to do the same things on the other end as well because the rectal ulcerations are just as bad and painful for the child as the oral ulcerations are. Alopecia is one of the things that we see and often people think of as being the big common side effect of chemo drugs. It's important that children start looking at wigs or other ways of dealing with the alopecia before they lose all of their hair, because then they can start getting used to the idea. With children, it's important that we do teaching so that they become aware of things that could possibly happen and how the things are going to be done around them, because they aren't as savvy about things that happen like the alopecia. They just know that they're kids and that this is how their life is at that moment, not so much what's happened to other people. They may have mood changes. They may start to get a moon face if they're on steroids. Hemorrhage is another issue that goes along with it, because as we start affecting the bone marrow and the production of blood cells in the bone marrow, we also affect platelets. And so with hemorrhage, we may need to give platelet concentrated cells to the patient as a transfusion. Anemia also goes along with that. And we may give them erythropoietin, but at the same time, we're trying to slow down the production of cells in the bone marrow with chemotherapy. So often erythropoietin isn't given until after therapy is completed. Children often are getting transfusions during their treatment for their anemia. They may have nausea and vomiting. We're going to use some of the more standard drugs for dealing with the nausea and vomiting. They may have altered nutrition. It's important to maintain their nutrition because a compromised nutritional status can contribute to reduced tolerance to their medication, an altered metabolism of their chemotherapy drugs. It can result in more prolonged episodes of neutropenia and also increased risk for infection because it affects the immune system if you're not well nourished. But then going back to having mucous membranes that are sore, you're not really wanting to feel like eating in that case. And so sometimes these kids are getting NG feedings because they physically are not able to take down the food that they're getting, or they may be on parenteral nutrition because they have so much nausea and vomiting that it is a more consistent way for them to obtain their nutrient requirements. They may have neurologic problems. One of the most common neurotoxic effects of medication is severe constipation, which is caused from decreased bowel innervation. And then when you consider that they often are on opioids for their pain, on top of that, these kids can have rather extreme constipation. Hemorrhagic cystitis is a side effect of chemical irritation of the bladder from the chemotherapy or radiation. It can be prevented by making sure that they get liberal oral or parenteral fluid intake at least 1.5 times the recommended daily fluids. So if you think about it, your book talked about that being 2 liters per meter square per day. So another reason we do the BSA calculations, to make sure that they're getting enough fluids for their requirements. Frequent voiding immediately after feeling the urge, because the longer those irritants stay in the bladder, the more irritation they provide, making sure that they void immediately before going to bed, possibly having one nighttime void as well, and that they void immediately upon arising. Again, we're trying to decrease the amount of time that chemotherapy medication is sitting in the bladder. And finally, administration of the drug early in the day to allow for sufficient fluids and frequent voiding throughout the day. And administration of Mesna, which is a drug that inhibits the urotoxicity of cyclophosphamide and ifosfamide. So we talked a little bit about bone marrow transplant just a minute ago. And allogenic bone transplant involves matching a histocompatible donor with the recipient. And the cells are aspirated from the donor and then given to the recipient. And it's limited by the presence of suitable bone marrow donors. So periodically we hear about things like having your blood tested or having things checked out to find out whether you could possibly be a bone marrow donor. Children undergoing bone marrow transplants are usually hospitalized for several weeks because they need to have numerous procedures performed, like insertion of venous access devices and administration of intensive chemotherapy and irradiation, and they're under strict infectious control precautions. Basically, what happens with them is that we often destroy their body's ability to fight off the bone marrow transplant that they're going to get, because we don't want them to reject it. And then during the period after transplant and before the new marrow begins to adequately replacing granulocytes, the child is extremely susceptible to infection, and any infection can be a life-threatening situation for them. And so it's very important that somebody's there to monitor these kids very closely. Hemopoietic stem cell transplant, the donors can be relatives or non-relatives, but they are antigen matched or mismatched. And then peripheral cells may be used, and stem cells from umbilical cord blood can be used. We often hear about moms that became pregnant so that the baby that they delivered would be able to donate stem cells for the child who's already living that had cancer. There's some ethical debate about that, but when you're a mom and your child is dying, you'll do anything for your child, including have another one. Cells are given via IV infusion after the bone marrow has been ablated. So in other words, they've had chemotherapy to shut everything down. And then the new cells repopulate the bone marrow. Hematopoietic stem cell transplantation is used to establish healthy cells in both malignant and non-malignant disease. And the ablative therapy is high-dose combination of chemotherapy with or without irradiation to eradicate unhealthy cells and suppress the immune system to prevent rejection. Some of the risks that are associated with it include a significant risk of morbidity and mortality. Also, graft versus host disease, which is one of the major issues involved with this. Even if you didn't think about the whole idea of shutting down and destroying the bone marrow and also shutting down the immune system to that degree before getting the stem cell transplant. Also, getting overwhelming infection during the process, having severe organ damage, because again, we are killing things off to such a degree in the bone marrow and the immune system that it affects other organ systems as well. However, the cure after hematopoietic stem cell transplantation occurs in up to 60 to 70% of cases. And so you can see why people feel like with those kind of odds, it may be better than other options for them. As far as family concerns with it, choosing stem cell transplantation is a difficult decision. The child faces death without transplantation, but you have to prepare the child for all of the things that place the child at great risk. There's no rescue procedure if there's complications except another transplant. And as far as nursing considerations are concerned, you're looking at extreme levels of infection control, also supporting the family, supporting the child. They are in extreme isolation situations where that child cannot leave that room because of the risk for infection is so high. And then, of course, preparing them to go home, because even when they go home, they will not have completely established a full immunologic system yet. And so they're still at risk for infection. And so then you have to look at family members and the prevention of infection at home. The umbilical cord blood stem cell, they use it because it's rich in hematopoietic stem cells for use in children with cancers. The stem cells are found with high frequency in the circulation of newborns because that newborn is still growing, and these are still things that are being established in their body. The benefit of umbilical cord blood is the blood's relative immunodeficiency at birth. And, like I've said to you before, at birth, kids don't fight off infection very well. They also don't tend to reject organs. And so in that way, these cells tend to be a little less dangerous than some of the other cells. It allows for partially matched, unrelated cord blood transplants to be successful. With autologous bone marrow transplant, it uses the patient's own marrow collected from disease-free tissue. It's frozen and then sometimes treated to remove the malignant cells. And it has been used to treat neuroblastoma, Hodgkin's disease, non-Hodgkin's lymphoma, Wilms tumor, rhabdomyosarcoma, and Ewing's sarcoma. Peripheral stem cell transplant is a type of autologous transplant, but it's a different type of collection from the patient. They stimulate the production of a high number of stem cells and then collect the stem cells by a pheresis machine, again, sort of like the hemodialysis machines, but a little different. And then the stem cells are separated from the whole blood, and the remaining blood cells and plasma are returned to the patient after the apheresis. The stem cells are frozen for later transfusion for the patient. So basically, they take these cells, freeze them, put them away, and then the patient undergoes all the chemotherapy and everything to shut down the bone marrow and the immune system. So I kind of wasn't sure whether I wanted to put these slides immediately after the stem cell information or not, but at the same time, I felt like it was important to have it at this point. Kids with cancer get a lot of blood products, whether they're getting stem cells, packed red blood cells, or plasma, or platelets. They get a tremendous amount of blood. And so we have to be aware of what happens with transfusion reactions. Hemolytic reaction is the most severe reaction, but it's very rare because of how carefully we type and cross the blood. The ABO incompatibility is the most common, which is really scary because we should be looking very closely at the blood to make sure that we're not giving B blood to an A person or A to an O, things like that. So, it's one of those things where you as the nurse have to be very diligent to make sure you're giving this child the right blood. Febrile reactions are also fairly common with the fever and the chills. Allergic reactions with urticaria, pruritus, and laryngeal edema are fairly common as well. All of these, of course, you're going to stop giving the blood immediately when they start having those symptoms, and blood is going to be drawn from the child to see what kind of reaction they're having to the blood. We're also going to be doing labs on the blood itself to see whether there's any bacterial contamination or whether they typed that blood in properly. But basically, they're going to do labs on the blood as well. Air emboli can occur when blood is transfused under pressure, so you definitely want to make sure that there's absolutely no air in a blood transfusion tubing. They can develop hypothermia as well, and they can get electrolyte disturbances, especially hyperkalemia. And so if you think about it, that's something that we see with breakdown of the red cells, and we want to make sure that we're not infusing the blood too fast that it may be causing hemolysis of the cells. And so then we also want to look carefully for signs of renal impairment when we start seeing this, or if the child already has renal impairment, this may increase the risk of hyperkalemia. In some cases, we see delayed reactions to the blood transfusion. And so with that, they may have gotten an infection from the blood, like hepatitis or HIV, malaria, syphilis, or many other different infections that can be delivered through the blood. Blood banks test for infections vigorously and they discard the units of infected blood, but that doesn't mean that they don't slip through every once in a while. And so it's very important that families understand that there is that risk and what kind of symptoms that they need to be watching for with their child, and the nurses in the hospital need to be watching for those symptoms as well, because often these kids with cancer are in and out of the hospital quite frequently. They can also get a delayed hemolytic reaction where there's destruction of the red blood cells and a fever 5 to 10 days after the transfusion. And so they need to be observing for post-transfusion anemia. So here's the child's gotten blood and they've gotten all nice and pink and gorgeous for several days, and then all of a sudden they're pale again. And that would lead us to feel that we've got a hemolytic reaction happening. So one of the blood cancers that we're going to look at today is leukemia. And leukemia describes a very broad group of malignant diseases of bone marrow and lymphatic systems. It's a complex disease, and there's various forms of it. The classifications have become increasingly complex as we're discovering more and more about the disease. However, the two forms that are generally recognized and are the most common are the acute lymphoblastic leukemia, or ALL, and acute non-lymphoid or myelogenous leukemia, which is AML. It's the most common form of childhood cancer, and there's 2 to 5 cases per 100,000 Caucasian children younger than the age of 15. It's more frequent in males over 1 year of age, and the peak onset is between 2 and 5 years of age. We've found out enough about leukemia over the years and how to treat it that we now have about an 80% survival rate compared to even back in the late 70s when a lot of kids were dying from leukemia. Chromosome studies need to be done on children with leukemia because what we know is that trisomy 21 children have 20 times greater risk for developing ALL, and children with more than 50 chromosomes on leukemic cells have the best prognosis. So the chromosomal study not only tells us who's at risk and who probably has it, but it also tells us who's going to respond to the treatment better than the others. There's also specific translocations of chromosomes on leukemic cells that can also affect their prognosis. Pathophys is that there's unrestricted proliferation of immature white blood cells in the blood forming tissues of the body, and that no tumor is present, but it has the same neoplastic properties as what we see in solid cancers. The liver and the spleen are the most severely affected because if you think about it, these are abnormal cells and they're being filtered through the liver and through the spleen, and so we start seeing a hepatosplenomegaly with them. And although it is an overproduction of white blood cells, the acute form often causes a low leukocyte count. Immature cells do not attack and destroy the normal blood, but destruction takes place by infiltration and subsequent competition for metabolic elements. So in other words, these abnormal cells are getting all the nutrition and the healthy cells aren't. Also, we have depressed bone marrow function with leukemia. So the consequences are that we have depressed bone marrow function, so we get anemia from decreased red blood cells, infection from neutropenia, and bleeding tendencies from decreased platelet production. The spleen and liver and lymph glands show marked infiltration, enlargement, and fibrosis because they have all these abnormal cells going into them. And so when we look at the diagnostic features, it's based on history and physical, peripheral blood smears, which show immature leukocytes and frequently low blood counts. The lumbar puncture is done to evaluate the central nervous system involvement because, again, when you have a cancer in the blood, it's going everywhere, including into the nervous system. And so there's more chance of metastasis into the nervous system. They also do a bone marrow aspirate or biopsy, and that will show how the bone marrow is not producing these blood cells. The therapeutic management is chemotherapy, and in some cases they'll do cranial radiation, and then they can also do stem cell transplantation for this disease. There's 4 phases of therapy for leukemia. The induction therapy lasts for 4 to 6 weeks. The CNS prophylactic therapy is an intrathecal chemotherapy. So in other words, we're going to put the chemotherapy into the spine, into the CNS. Then we have an intensification or consolidation therapy to eradicate any of the residual leukemic cells and to prevent resistant leukemic clones. And then maintenance therapy is done to preserve the remission. So this kid is on a fairly long period of chemotherapy. However, what we've found is that this is why we have this 80% cure rate for leukemia, is that we're treating it at all levels of potential. As far as prognosis goes, if the relapse occurs after stem cell transplantation, the prognosis is very, very poor. Identified factors for determining the prognosis is the initial white blood count, the age at the time of diagnosis, the type of cell that's involved, the gender, and the karyotype analysis. When we look at the nursing considerations, assessment is extremely important, again, because these kids are at high risk for infection, they bleed easily, and they also are anemic, and so they're having all of the symptoms that are associated with profound anemia. We have a number of different diagnoses that we use for them based on their symptoms, and the planning phase is how we're going to do each one of these phases of treatment. Also, what kind of support we're going to be giving them as nurses, and teaching that we're going to be providing to the child and to the family. As far as implementation, we want to prepare the child and the family for all the procedures, because we just went through all, having an LP and having MRIs done and all this blood work, and probably getting implants done for the chemotherapy, and controlling pain and prevention of complications of myelosuppression. Lymphomas are neoplastic disease originating in the lymphoid system, and it metastasizes into the non-nodal sites. Hodgkin's disease has a more prevalent pattern in patients 15 to 19 years of age. Non-Hodgkin's lymphoma, or NHL, is more prevalent in children that are younger than 14 years of age. In the neoplastic disease and Hodgkin's disease, it originates in the lymphoid system. It often metastasizes to the spleen, the liver, the bone marrow, the lungs, and other tissue. And it's classified by its histologic type. The classification of Hodgkin's disease is it's a classification A, meaning it's asymptomatic, or B, in that it has a temperature greater than 38 degrees or 100.4 for 3 consecutive days, combined with night sweats, unexplained weight loss of 10% or more over the previous 6 months. And they can go back and forth between A and B, because when they go into remission, they're in A, they're asymptomatic, but then when they start having symptoms again, then they're a classification of B. As far as diagnosis is concerned, we look at things like asymptomatic enlarged cervical or supraclavicular lymphadenopathy is the most common. So in other words, enlarged lymph nodes in the cervical region or the supraclavicular region, cough, abdominal pain, and anorexia. We do CBC and T cells and radiographic tests. We do lymph node biopsy for diagnosis and staging. The presence of Reed-Sternberg cells are what we're looking for. Also, bone aspiration if the stage has become advanced. We're looking for metastasis. Some of the ways that we manage Hodgkin's disease is radiation. Chemotherapy also can be used alone or with radiation, although in many cases radiation is done as the primary treatment. Prognosis is actually fairly good with Hodgkin's disease, and the nursing considerations is that we need to prepare the child for the diagnostic procedures, prevent side effects if possible, and prepare to treat the side effects. Also give the child and family support. With non-Hodgkin's lymphoma, it's approximately 60% of the pediatric lymphomas, and the clinical appearance is that it's usually diffuse rather than nodular. So Hodgkin's, you're going to see these nodule lymph nodes that are enlarged. Non-Hodgkin's, you're not going to see those big giant lymph nodes. The cell type is undifferentiated or poorly differentiated. The dissemination occurs early, often and rapidly, and you get mediastinal involvement and invasion of the meninges. So in other words, this tends to spread rapidly. As far as management, it's similar to Hodgkin's disease without staging. The therapeutic management is also very similar, and prognosis is not quite as good as the Hodgkin's form is. And our nursing considerations are similar. Brain tumors are the most common solid tumors in children. The infratentorial tumors are about 60% of the cases, and they occur in the posterior third of the brain, primarily in the cerebellum or the brainstem. The supratentorial tumors occur in about 40% of the cases, and they occur in the anterior 2/3 of the brain, mainly in the cerebrum. The brain tumors and neuroblastomas are derived from neurotissue, and again, they're derived from the embryonic tissue, and they account for about 20% of the childhood cancers. The tumors are difficult to treat, and the survival rates are pretty poor. And that has a lot to do with that embryonic tissue form, because it was made to spread. It was made to grow. And so when it's glial cells, which is a embryonic cell form, it makes it hard to control. So when we're diagnosing, the signs and symptoms are related to the anatomic location and the size of the tumor, as well as the child's age. The presenting signs are similar to what we would see with any neurologic disorder. And we need to have a neurologic evaluation. They do MRIs, CTs, EEGs, angiography, and lumbar punctures as part of the diagnostic evaluation. And the definitive diagnosis is based on tissue specimens that they received during surgery. The treatment depends on the type of tumor, whether they do surgery, whether they do radiation or chemotherapy. And like I mentioned earlier when we were talking about radiation, often they will do radiation to shrink the tumor so that when they do surgery, they are able to get the tumor easier than if it was all enlarged inside of the brain. The prognosis is dependent on where it's located in the brain and how much is involved, whether there's metastasis already present or not. As far as nursing care management, we prepare the child and the family for the diagnostic and operative procedures, and we establish a baseline of data. When we assess, we are getting that baseline so that when the child returns from surgery, we know how this child was before surgery. Post-operative care, often there may be some drainage involved, and the child has a big bandage on their head that we don't remove. And so if there's drainage, we draw. And so if you see the drainage, maybe you've got a little area that's 1 inch in diameter, maybe the size of a quarter. You actually will take a pin and draw around that 1 inch area. We want to see whether the drainage is expanding or not. We're going to support the child and the family. We're also going to be looking for signs of change in their level of consciousness. Neuroblastoma is the most common malignant extracranial solid tumor in childhood. The majority of tumors develop in the adrenal gland or in the retroperitoneal sympathetic chain. Other sites for neuroblastoma are the head, chest, neck, and pelvis. Metastasis has already occurred in most cases before the diagnosis is made. So if you think about it, neuroblastoma, because of where it primarily develops in the abdomen, can grow quite large before anybody's going to see any sign of it because there's so much room in the abdomen for it. And so as a result, it tends to go into a higher stage before they ever see any symptoms. The diagnostic evaluation is to locate the primary site or sites of the metastasis. We look for signs and symptoms that will depend on the location and the stage of the disease. X-ray studies and bone marrow evaluation are used to evaluate it, and since the kidneys may be involved, they may do an IVP to find out if and how much the kidneys are involved. Remember, the adrenal glands sit over the top of the kidney. The therapeutic management is that it's important to stage it before they establish a treatment plan, and they do surgery to remove the tumor and obtain biopsy specimens. Radiation and chemotherapy is done. They may do bone marrow transplantation or stem cell rescue treatments. Again, remember, in many cases when we're doing stem cell, it's sort of the last hurrah because the cancer has spread so much. The prognosis for neuroblastoma with all stages grouped together is about 95% in the low risk stage and it's 30% in the high-risk stage. So the more metastases there are, the less likely, the lower the survival rate becomes for the child. In general, the younger the age at diagnosis, the better the prognosis is. And they may have spontaneous regression as the embryonic cells mature and with development of a more active immune system. So that concludes our discussion about oncology. Again, I want to encourage you to um, be aware of how to um, calculate the absolute neutrophil count and what the meaning of that is. Also, to review your case studies and think about the questions that they're asking with them and how you would answer those questions, because that's how you develop the critical thinking involved in learning about cancers. So I will see you all soon.